Thank you very much. This is where I live, Truckee, California. I was at Cedars-Sinai Medical Center in Los Angeles, just outside Beverly Hills, 1,000 beds, 2,000 doctors, and after 25 years, I needed to recharge my batteries. So I moved up there to be a ski bum and a cowboy and played the piano in some blues bars. And the hospital serves a community, and I really wasn't sure I wanted to practice medicine there. But there are 50,000 people who live up in the mountains out there. It's about 2 hours from Sacramento, and it's about an hour from Reno, Nevada. And those places have got regular hospitals. Sacramento's the state capital with UC Davis and other great hospitals right at these two tables. We have significant snow issues, a lot of weather issues, and there were 0 cancer services. So we had 100% out-migration of our patients. ASCO's mission is to reduce cancer health disparities. So when the hospital said, Larry, you want to do this? And I said, you don't want to do this. And they said, okay, well, let's see what it would take to do this. You can't have a greater experience of addressing healthcare disparities. So what were we going to do? We set up some guiding principles. Number 1, we were going to provide universal access to care. When you're in a small community, you take care of everybody. Every kind of insurance, no insurance. We don't even care if you're legal or not. If you're living in our community, we're going to take care of you. We'll figure out how to pay for it later. We have to think about what fears from cancer are enhanced in a rural setting. We had to reach out to regional thought leaders. And they're regional thought leaders at Stanford, at UC San Francisco, at UC Davis, and they're all the smartest guys on the block, right? So I know, once you've had some battle scars, you know that the guys who really know how to do brain tumors are at UC San Francisco. You try telling that to the guys at Stanford, okay? They invented brains, right? So it's but when you've had a little street smart behind you, you can figure out where the specialists are that you can really count on and develop relationships with. We had to use technology to lessen our sense of isolation in the rural setting, and we absolutely needed to keep the local business community and community leaders engaged so that ultimately they could pay for something as big as a cancer program. Fear is the primary biologic emotion. Your ministers may tell you it's love. It's fear, okay? I mean, death, pain, disability are universal. Every single one of our patients have that fear, have those 3 fears. But these 3 fears are significantly amplified in a rural setting. That's getting disorganized care, becoming a burden on your family and caregivers, if you have any family and caregivers up there, and getting yesterday's therapy. That is clearly the most pressing fear. So how do we deal with that? All of us in this room are in a perfect storm. We've got a rapidly increasing population that's greater than 65 years old. It's the vast majority of our patients, and we have an exponential knowledge-based growth. We've got unpronounceable MIBs, NIBs, MABs, and ZUMABs coming out every 3 months. There's no way to stay on top of that, and new guidelines are happening almost every 3 months. We have a legacy medical education culture. We're supposed to be smart. We're supposed to be able to keep up with the literature. We're supposed to know what's happening. And how do we know what's happening? By drug reps. Sorry, another cheap shot. But really, how are we really supposed to know what's going on? We're fighting this war of an exponential knowledge base with yesterday's thinking. When we decided to develop our program in the mountains, we wanted to reach out to an NCI-designated comprehensive cancer center. There are only 8 in California. There are none in Nevada. Now, Nevada was closer, and business people in my community said, come on, just reach out to the Nevada hospital. I said, no, if we're going to do this, we're going to develop a relationship with one of these guys. Don't feel bad if you're not on that list. Cedars-Sinai isn't on that list, and they're really pissed off about it. But Stanford, UC Davis, and UC San Francisco were 3 options for us. UC Davis had a significant commitment in telecommunications, in telemedicine, to service that entire Central Valley area. So we started the UC Davis Cancer Care Network with three other regional places: Marysville, California, Merced, Bakersfield, and Truckee. And we're the smallest and the most remote from the mothership in Davis. And we have no financial ownership, anything like that. It's a handshake relationship of intellectual transfer of knowledge. Okay, so who's this guy? Vilfredo Pareto, in 1896, studied land ownership in Italy. He was an economist, and he found out that 80% of the land in Italy was owned by 20% of the people. We call that the 80-20 rule of human behavior. That means 80% of the work done is done by 20% of the group. You all know that. 80% of the patients admitted to all of your hospitals are by 20% of your medical staff. And over 80% of all the Little League coaches' headaches come from less than 20% of the parents, right? But it's also a biologic. In cancer, there are 20 major sites, but 4 of those sites comprise 80% of our patients. That's colorectal, prostate, lung, and breast cancer. So if you're going to start a program in the middle of nowhere, from nothing, with no legacy culture, get good at managing those 4. You're going to build your infrastructure. You're going to train the surgeons, the pathologists, the primary care docs on how to do those common diseases, and you'll be able to then know how to approach a lymphoma, a brain tumor, or sarcoma. Everything's going to work out that way if you pay attention to that 80-20 rule. Well, how do you get good at that? What is a tumor board? Now, everybody here knows what a tumor board is, but what really is it? They started after the Second World War, before there was such a thing as a medical oncologist. It's a multidisciplinary conference. We know who the members are of the tumor board, but the most important thing, it's a safe room. So going back to medical school, we all remember getting pimped by our senior resident, right? The attitude, that, for those of you who don't know what that means, it means being made to feel like you're an idiot by some bigger idiot who's above you in the pecking order, who does not understand human relationships because he was selected to be an idiot, okay? So a safe room is the single most important definition of a tumor board, where you're free to say, maybe I made a mistake. You're free to say, what do you think I should do? Or what does that mean? And if you get shamed, that tumor board needs to shame the shamer. Now, that's in the ideal world, but it really can work this way if you set the culture like that. In community hospitals, they have general tumor boards. In academic centers, they have disease-specific tumor boards. It's a necessary element for our accreditation from the American College of Surgeons. Everybody knows that. So at UC Davis, they redesigned their tumor boards so that every Monday at noon is colorectal tumor board. Every Tuesday at noon is prostate tumor board. Every Wednesday at noon is lung cancer, and every Thursday at noon is breast. We're off on Fridays. Got to take a break. Yeah, I got to go skiing. So it's our new doctor's dining room. We don't go to the doctor's dining room to hand out our business cards. We go to our doctor's dining room to get smart at lunch. Okay? We go to experience this.
Not everybody is going to live in a big city where there is highly specialized care, but you can bring state-of-the-art care, clinical trials therapy to patients regardless of where they are.
We're a very small hospital out here in Lake Tahoe. We're really tiny. And we're about an hour from a mid-sized city, Reno, and about 2 hours from the state capital in Sacramento. The virtual tumor board allows us to meet on a regularly scheduled basis with thought leaders at an academic center. It allows community facilities, community hospitals, to present a case at an academic place within a week of making a diagnosis.
We can look at the CT scans together, we can look at the pathology together, and reach a joint decision about the best treatment for that patient. So the advantage for our community affiliate sites is this puts them in contact directly with specialists every day of the week.
The benefit to the physician to participating in a virtual tumor board is the sense of security that he or she is doing the right thing and as close to the cutting edge as possible.
In general, we do tell our patients, I'm going to present your case to the tumor board. Patients like that because then they say, oh, you get 20 opinions for the price of one. All the different specialists get to weigh in on the problem.
These tumor boards have allowed me to feel better about what I do. And if I feel better about what I'm doing, the patients are going to get better care.
And who's the benefit? Who benefits from this? The patient.
Really, really want to thank Bonnie and the whole team for producing that. And I don't know if you guys noticed, but we kind of stuffed somebody into our tumor board. Tony over there, okay? We had sort of an empty space. So now you're in the middle of nowhere. You've got these virtual tumor boards. What good is it? So I want you to look at this slide. This slide came from Larry Einhorn, who in 1974 started his clinical trial on using cisplatin for advanced testicular cancer. And at that time, in 1974, the probability of living 18 months was 38%. Okay? Now, he published his first abstract in 1976. In 1977, I started at MD Anderson, where he used to be, and he had moved out to Indiana. So we were kind of like involved in this whole thing, and we were learning how to give cisplatin and really causing a lot of damage at the beginning. But by 1978, the probability of living 18 months was up to 80%. Now that's terrific. That's terrible. It took 4 years to make a difference. If you were living within 200 miles of Indiana University and were part of an academic virtual tumor board program, and you could send your patients into their clinical trials because you knew about those clinical trials, your patients would live. And if you didn't, your patients would die. It's very clear. And if you think it's changed today, you're wrong. It may not be 4 years, but I don't care if it's 4 months. If you're behind the 8 ball on that, that's not where you want to be. You want to be right there where the thought leaders are coming up with the new thoughts, with that new knowledge. So we had a lot of patients now coming to us from further up in the mountains, really tiny hospitals that are on life support, 5-bed hospitals. They can't keep a primary care doc in there. And patients who aren't that educated necessarily, they're smoking, there are all kinds of problems with those patients, and they have to come to see us for a day 8 CBC on chemotherapy in a snowstorm for an hour, in an hour drive each direction. Or they have to come back for every 3-month breast cancer check. We said, look, we're pretty comfortable in front of cameras now. Why don't we reach out to these other places, get a nurse practitioner hired by the other small facilities, and we'll be the docs talking to them. We will integrate our diagnostic imaging so that we can look at all the images. We've not been able to integrate our laboratory studies for all kinds of HIPAA nonsense, but at least we can scan things in so we can see what the blood tests are. We allow these smaller hospitals to stay in business. They can do the CAT scan. We don't have to do the CAT scan. They can do that. We can keep those patients at their homes, not even at our homes. So we call that a telemedicine visit. Now, I had to pixelate this for HIPAA again. So when I would be at my desk, that's what I would be seeing. I'd be seeing my nurse practitioner on the right, the computer at her desk, and a patient on the left. And I'm that little tiny thumbprint on the right, just so that I can see that I'm there, right? They're seeing the flip side of that. They're seeing me really big on that screen and themselves very small. But what we do this is really important, is we turn their picture into a tiny little thumbprint and move it right up there under the camera. Why? How many of you guys have had a Skype with somebody or a FaceTime with somebody, and everybody's looking down at the screen? You're looking at the eyes of the person in the screen, but you're not looking at their eyes, because you're looking at they're seeing the top of your head instead of looking at their eyes. And if you're going to do a telemedicine visit that's worth a damn, you're going to have to bind, you're going to have to connect with those patients. So all you got to do is move their picture up into right below that camera. It approximates it pretty well, and it really works. So that then I can use the rest of this valuable real estate for looking at the CAT scan or looking at the EMR and my flow sheets and do the doctor job, but still do the doctor job by looking at the patients. The patients love it. The universal complaint, though, is, Larry, I miss the hugs. And they'll sometimes drive just to get the hugs, and don't discount how important that is. So here's what we built. Every day, we have this solid pipeline of knowledge, new knowledge, from an academic medical center way out to Truckee, California. A few years ago, we opened up our first telemedicine clinic in Portola, California. 6 months later, it was in South Lake Tahoe. 6 months later, in Quincy, California. And 6 months later in Loyalton. We call that a synaptic knowledge network. So imagine your internet at home, your Wi-Fi signal, and you're online and you want to go outside, and all of a sudden the signal dies. We all know that inverse square law works for everything. Knowledge, our assumption is that knowledge does the same. Knowledge is going to decrease over the distance from where the knowledge is produced. Critical knowledge. We think this system actually sends that knowledge way out there and might be a model for addressing a disparity in cancer care that could be grown. So what if we did this for the rest of the UC Davis Cancer Care Network? Or what if we did this for the other 69 NCI-designated cancer centers in the United States? Wouldn't that be an interesting way to take something that a bush pilot in Alaska needed and that might have applicability in other situations? Well, what are the results? What was in this for UC Davis? Why the hell should they do this in the first place? Well, the network hospitals provided 8% of all of UC Davis's clinical trials. They provide the IRB for us. We can't have an IRB. They provide all that backup, and we're putting patients on clinical trials to a significant amount. They became our preferred referral site. If I'm presenting a lung cancer case to UC Davis, they're going to get the operation. I'm not going to send the operation to UC San Francisco, okay, or you guys, okay. I'm going to send it to the guys we're talking to every day. They're getting the sarcoma surgeries. They're getting the pancreatic surgeries. So that's a significant what's in it for me for the academic center. Lastly, it provides a measurable community outreach, which is a necessary criterion for maintaining the comprehensive designation with the NCI. And you don't get any more outreach than Truckee, California. What's in it for Tahoe Forest? We've got a whole bunch of accreditations and certifications that we worked very hard to get. We've gone from 100% out-migration when we started the program to 62% in-migration. That means not from within our 50,000 people, but from outside of our catchment area. Why the hell would somebody do that? Why? Why would all these patients be coming to us instead of someplace else? We can't demonstrate that they live 1 day longer. We can't demonstrate that. Why would they would only do that for the sense of security that our transparent relationship with an academic mothership turns into a greater sense of security that they'll at least be at the state of the art. And we think that is good business. We've gone up to 3 medical oncologists and 1 radiation oncologist. I don't count. I'm not seeing patients. I'm just the medical director. I'm old. We've become a significant revenue center for our rural hospital. We support these essential services like labor and delivery, pediatrics, and primary care that can bankrupt a small hospital. So what are the take-home points? Number one, appreciate the 80-20 rule. Get good at those 20% of diagnoses that account for 80% of all your patients. Now this doesn't have to be restricted to oncology. Get smart and stay smart at lunch. Develop disease-specific, case-based conferences with regional thought leaders. I didn't say tumor boards. You can break up, there's cancer, there's cardiology. It's another big-ticket item in healthcare. And you could divide cardiology into muscle weakness, rhythm disturbance, valvular disease, and coronary artery disease. You could do the exact same model for cardiology. And if this is worth a damn, it would be worth a damn for cardiologists to try this as well. It's not a bad idea. And lastly, technology should be used for doctors and patients, not hospital bean counters. Make sure that that technology helps improve your communication from doctor to doctor and your communication from doctor to patient. Use it to enable effective outreach to remote patients and build all of your systems to address your patient's specific fears. Thanks a lot.